Good afternoon. Welcome back to our second part of our workshop on AI sustainability, our people-centered approach. This is our afternoon session. Well, now I'm going to introduce to you DrHannah Mary Thomas. She's going to present to us her work entitled "Bigger Isn't Always Better: A Sociotechnical Perspective on AI for Health." DrHannah is an imaging scientist in the Department of Radiation Oncology at the Christian Medical College, Vellore, India. So, Hannah, thank you so much for your time and for being with us today. It's my special pleasure to meet you once again. I think we met before November 2022 when you were in person here in our campus. So, yeah, please, for one, feel free to introduce yourself. Thank you.
Thank you so much for that warm welcome. So, what I will be speaking about is a little bit from the perspective of what we've been trying to do at a large tertiary care center in India for the last 5 years, and also try to align it with some of the goals that are part of the sustainability goals, but also goals that we set for ourselves to make sure that what we are building is not for one particular project, but for that can be used at a large institutional level, and also the lived experience can lead to things that can inform others how things can be done or should not be done, both ways. So just to give context, so I see from the list of speakers, I'm the only one currently from the BRICS nations. So why should we in this small room care about what happens in another part of the world? So uh, just these 5 countries alone, with India included, contribute to 42% of the world population, about 40% of land mass, and we contribute to about 17% of the global GDP. So what it happens at the global level for AI definitely matters to us, matters to India, and that matters to the world as well. That's how I think about it in the large perspective. A little bit about where I come from. So I'm from Christian Medical College, Vellore, which is a large tertiary care hospital which was founded in 1900. And we are the second largest teaching hospital currently in India, with a so we cater to around 3 million patients annually as outpatients, with about 145,000 patients treated as inpatients for different ailments. And from that perspective, it's as large as you can imagine a healthcare enterprise to be. A little bit of just to put into context what my background is and how I ended up doing what I'm doing currently. So my background is in physics. I started as a research fellow in medical imaging in 2006, and I started working on CT reconstructions back then. I did some work with pathology image segmentation for white blood cells. My PhD was in positron emission tomography imaging based segmentation algorithms to be used in oncology. I did my postdoctoral fellowship at the University of Washington, where I trained myself to lead clinical trials and also look at the use of medical images to stratify patients and improve standard of care. In 2020, I decided to come back to India. 3 years I was in the US. So 2020, I decided, yes, with this background, I want to set up something that is useful both at an institutional level and also at my national level. So that started off as a small effort in 2020. So I co-founded the Quantitative Imaging Research and Artificial Intelligence Lab. This is one of the only AI research labs that currently reside within a tertiary care hospital in India. So it is one of a kind, and also all of the challenges of being the first. Um, I've also had a brief stint at the University of Surrey as an Institute of Advanced Science Fellow in 2022-23. So that's when I have met some of you during my stint over there. So what we currently focus on from the lab that we lead is on integrating image descriptors specifically from radiological images. And these image descriptors, we call them broadly as radiomics. And the idea is to use radiomics as part of in AI models for clinical decision support. The other thing that we currently focus on is to leverage diverse image modalities. So we don't restrict ourselves only to one image modality. So we are also looking at multimodal for enhanced disease prognosis and classification. Just to set the scene in context, so in 2020, what we did was just a back of the envelope search in PubMed about the research that happens specifically in image descriptors or radiomics. And this was the scene. So 35% of the work that is being reported is from China, and the other leading contributor is from the US. You will see that the rest of Europe is represented in the other half of the pie, with only 5% being contributed by Brazil, India, and 3 other countries. If you see, Africa is not represented in this line of work at all. So this is where we started, and why it was necessary to create sustainable goals for ourselves, because we were pitching ourselves against something that was non-existential at that moment, but also to make sure that it doesn't stop with just the one project that we were trying to lead. So this is the broad promise of AI that we often hear in the context of healthcare. So we always want to, profess and think that new ML and other AI technologies will help us improve access to quality healthcare, address just the lack of clinicians, also the uneven ratio of skilled doctors that we often see in low and middle income countries, um, to try and improve training and efficiency of healthcare personnel, specifically in leading complex procedures. So, in rural settings, in areas where there is deficit, AI can try and bridge that gap. We're also trying to look at AI to enable us personalize healthcare at scale. So while preparing for this particular talk, I was thinking, what exactly is sustainability of AI? in the context of healthcare. So some of the, this is not an exhaustive list, definitely, but some of the key areas that we're talking about is about developing and deploying AI solutions that can overall improve healthcare or health of patients or people in general. Also allow us to optimize resources that are available in terms of healthcare professionals, in terms of just healthcare technology, trying to reduce cost. Also, we've been largely thinking in the last 5 to 6 years about how to make sure that AI is ethical and also includes social responsibility. And we've been largely thinking about what is the long-term viability of any of these systems or technologies that we build into the healthcare system. So having said that, some of the challenges that we have when we deal with health, and specifically for health data in India, because when we want to build AI models, we need data. And health data in India currently, the biggest challenge is in terms of the quality of data. When we talk about data, it's also about the quality of care that's available in a large country as ours. Accessibility to these data sets. So these a large amount of and a large number of hospitals still remain paper-based. So when we are talking about building AI models, we are talking about data sets from a few institutions which may be fragmented, dispersed, incomplete in a lot of sense. Inequity, because again, because of accessibility, if it is not digital data from rural hospitals, from really centers which are not either for-profit or large tertiary care centers like ours, which although we are not for profit, but we do see a large number of patients. There is a lot of inequity of the data that we are dealing with. So there's inadequate data and unrepresentative data when we are building these models. Affordability, definitely for an institution, even like ours, it is difficult to set up the infrastructure, to sustain those infrastructures, to create digitization practices. Standardization of practices has been a challenge. So these are things that we are currently dealing with. So in terms of when we started thinking about the quantitative imaging research and AI lab, some of the things that we wanted to do was to make it sustainable by design. So I'll go through some of the things that we've done to ensure sustainability, but we're definitely not there yet. But these are some of the things that we've learned just by doing it. So the first thing is about problem identification. Is it really an AI problem to solve? Is the data available? If not, how do we manage to create good data, clean data, complete data sets? How do we build teams, workflow processes, infrastructures, software? And how do we manage all of this from a global scale to make sure that we still match up with what is required from a responsible AI perspective. Also building a large community that can continue uh, uh, working on AI both ethically and responsibly. So the first question that we started off this lab with is the main problem that is that I work on as part of my fellowship is on predicting recurrence of cancer or specifically head and neck cancer. So the clinical question for the radiation oncologist was, in any head and neck radiation patient, we decide the treatment based on the stage of the disease, but we say for the same stage of disease, different patients, some of them fail while others don't. We don't have a biomarker that we can currently rely on, a molecular biomarker. So what do we do that's the second best? So we said, yes, all of them have imaging. So at the point of outlining the tumor, can we use images to help us predict risk of failure, which will allow a decision support system to either intensify treatment or to create alternate management? So this is the first question that we started with, and it was important to find the right problem to work to create a use case for that can sustain this interest and also is relevant to the community. So the first goal was to make sure that the problem that we choose addresses an unmet clinical need, and it has to be relevant to our patients that we're looking at. So this is the approach that we have started with the first, and we thought this is the approach that will allow us to continue to be relevant in this space. So all our projects that we've taken after the first one have always been problem-led research, which can be aided by AI as a tool, not AI for the sake of just for doing AI. The second one was about data. So if we were to talk about CMC, we are actually positioned in a very, very comfortable space in terms of data because we are digital first for the last 23 years. So all our data, which includes EMR, lab, imaging, billing, pharmacy, teleconsultations, are all available as digital data. So, but the problem is they are not created in a way that is easily mineable. When we started working with the imaging data, we realized that it is standardized for visual reporting and not standardized for both visual reporting as well as quantitative analysis. When we build prediction models, it's not just enough to have imaging data or clinical data, but we also need to know what happened to the patient in terms of the outcome, because that's what we're modeling for. And as a large country, what usually happens is patients come, seek treatment, and they go back, and we lose them during follow-up. So we are not a country where we are all hospitals are networked to each other. There is no single registry that maintains what happens to the patient after they've completed their course of treatment, and especially in terms of a robust registry maintaining just survival data. Even that oftentimes we found is lacking. So it is in this setting that we looked at the available retrospective data, because we do see a large number of patients each year. So we're looking at anything between, just for head and neck, we're looking anything between 400 to 600 patients treated just by our clinic each year. So we said, okay, we have a lot of data to work with, but when we actually tried using this retrospective data, we found a lot of variability to begin with. So in terms of how the images are acquired, in terms of how the images are reconstructed, how the outlines for the tumors are defined. So this variability, we decided, okay, if we are going to begin with such a variable data, how reliable is our model going to be? So we had to decide between retrospective versus prospective. We knew retrospective was time consuming to just curate large quality data sets. Technological, so we also looked at what is available as open source data. We found that most of the data sets that are available are at least 6 to 10 years old, and technology in radiation oncology keeps evolving. So how the treatment and management of the disease is over this time also can create a bias. And outcomes, most often the outcomes in terms of if it's a recurrence or if the patient has actually survived or not, recurrence data or outcome data are not always available. So we decided we are going to do a prospective imaging trial, which will allow us to not only create good data sets, but also create more efficient processes, which can be then leveraged to create good data sets at a department level, at an institutional level, which we think we have to start somewhere, so that at least 5 years, 10 years down the line, we have good data sets to work with. We definitely acknowledge that it was additional cost in collecting and storing the data, and it's also time consuming to just wait for outcomes to mature, because once we treat the patient, we need to wait at least a year or two for a recurrence to occur, or follow up the patient for 5 to 10 years if we want to see what the survival data looks like. So this is what we've set ourselves up for, but um, uh, it's uh, it's encouraging enough to say that we've managed to create standard protocols for imaging all our patients who are treated for head and neck cancer. So at least 400 to 600 patients are imaged on a standard protocol each year since 2021. We have complete data sets as possible, so the imaging is acceptable not only for clinical use, so a radiologist or the radiation oncologist is able to use those images, and we also can run AI analysis. We found that there were certain areas where still paper was used, radiation oncology, some parts of it where so we created EMR systems, so all of the data becomes digital. We follow up our patients using teleconsultations right now, so we know we can follow up a large number of them, even though they don't come back traveling so far just to meet the patient, doctor after their treatment is over. We're also exploring the use of NLP for creating structured data from textual or historical content. The second one we realized was to sustain any long-term project, it requires a great team. And this is no different in AI, because AI, we know, requires a multidisciplinary effort, both to build models, to deploy the models, and to make sure that a large community adopts these models. So we've been actively building teams of clinicians, physicists, technologists, scientists, administrative staff, and international collaborators to help us work through this sustainably. So for each project that we take, this is the approach that, with time we've learned that it's important to have a clinical team lead, because as I said earlier, it is a problem-led approach. So the clinician has to be taking the lead, saying this is a problem that is worth solving. So they need to be there. We have a research lead and definitely an administrative person, because a lot of this requires additional permissions, both at an institutional level and at a national level, with all of the compliance that we need to be aware of. Also, we have local champions who will talk about these projects, encourage others to use, or at least start thinking about where AI can be used. Operational leads, definitely IT computational leads. And we have an educational and training component that's added to each of those teams, so the stakeholders feel completely involved. So this is our specific team for head and neck cancer that um, is currently leading the effort. But we do have a number of teams that have joined since 2020 who are working on their own individual projects. Coming to workflow and processes, what we found is we do have definitely very good processes in place to manage our digital data clinically, which is for everyday use. but there is a lack of clinical research environment, crosstalk. So for radiation oncology, this is what we had to build. So from the time an image of a patient comes in, we start with consenting the patient. So it is a consent process. All of the image annotations are then um, curated, de-identified, and stored. All of the clinical data is also stored for each of these patients. In terms of infrastructure, what we've done is we've made sure we have an institutional level infrastructure that can be used, but the outline that I've put in red, that is still not complete. So we've made sure that we have an infrastructure in creating a data warehouse, but we're yet to build analytics and intelligence on. We're also leveraging national level infrastructure, because at an institutional level, there's only so much that the institution is going to allow us to spend on creating infrastructure for AI. And so this is the way for us forward. In terms of software and models, we've tried to simulate models using existing data sets. So we learn from those existing data sets, both retrospective as well as open source data sets, to make sure that the data that we collect is as uh, complete as possible. We've also looked at simpler models when possible, and we've been creating federated learning approaches to have centralized models where we partner with other institutions to create these models. In terms of education and training, this is what we find that we need a cultural and social change if we want to see both speed and scale of adoption. So this is what we've been doing, is to create awareness, to create large groups that come together to talk about these issues, and also have both industry, technology, and healthcare workers working in the space. So these are some of our collaborations. I have just two more slides. So this is where we are after 5 years. We've imaged 1,200 patients prospectively. We've managed to complete 7 research projects in different areas apart from oncology. We have a institutional level informatics unit that's been put up. So this is what I strongly believe, and the team believes: to know and not to do is not yet to know. So we know that this needs to be done. So this is something that we are working towards. These are things that we have not tried, we have not been able to solve yet. Translating it to multi-institutional at a national level, we still don't know how to manage cost, because this is definitely a huge factor. And we still debate about, do we want to have country specific or global models. Um, so I'm happy to take questions if any, and also all suggestions are welcome. Thank you.
Thank you, Dr. Hannah, for your insightful presentation. I think we have time for just one quick question. We have a quick question, Hannah?
Yes, okay.
Okay, I have one. So just a curiosity, how can we comply with ethical issues when work with AI for healthcare? In your experience and given your talk, how you think we can comply with ethical issues when work with AI for healthcare?
So in terms of, I think it is important to acknowledge that the data is the patient's data. So the patients know that their data is being used for building these models, and they're also part of the advocacy groups. In terms of making sure that we are compliant, is to make sure that all privacy related data is definitely stripped off or de-identified before we even start working on any of the analysis um, for building these models. Also, I think it is important to make sure that all country specific, region specific ethical issues are complied with. So in India right now, this is an evolving space. In the last 5 years, we've seen a lot of regulations come in. Earlier, it was easier for anybody to take data and put it out on the cloud, but now it definitely people need to be aware of privacy and all of the ethical concerns that are there regarding AI. So compliance is definitely the way to go.
Thank you so much, Hannah.
Thank you.
Thank you.